Good morning, Sages. Thank you, Dr. Ng and Dr. Satava, for inviting us for this podium. Don't have any cool videos like my previous presenters, but nonetheless, we're very excited to present our work. The title of our study is called National Trends and Outcomes of Open Laparoscopic and Robotic Low Anterior Resections for Rectal Cancer Patients. Here's the list of Dr. Mark's disclosures. The other authors do not have anything to disclose. So, despite advancements in chemotherapy and radiation therapy, when it comes to rectal cancer, surgical resection is still the standard treatment and curative treatment for rectal cancer. For proximal and mid-rectal cancer, low anterior resection is the approach. So major randomized trials to date have shown non-inferiority of minimally invasive techniques when it comes to colorectal cancer treatment. To name a few, Color 2 and Korean trials have shown equivalent oncologic outcomes to open surgery and rectal cancer treatment. So informed with this idea and these results, we wanted to look at the national trend of LAR, comparing open groups versus minimally invasive surgical groups, including both laparoscopic and robotic cohorts. The primary variables of inpatient outcomes we included in our talk were length of stay, mortality, morbidity, and disposition. So based on the major clinical trials, we hypothesized that the rectal cancer patients undergoing minimally invasive LAR, especially robotic cohorts, will have reduced morbidity, shorter length of stay, and perhaps higher discharges home with any assistance. We used national inpatient sample. It is the largest and most representative and publicly available administrative database within the United States. It includes national database of hospital inpatient stay, including discharge records, as well as disposition and mortality rates. We looked at the years between 2009 and 2014. This is due to the fact that ICD-9 code did not include robotic codes until mid-2008. 2014 was the most recent database available at the time of the study. Diagnosis included rectal cancer with this specific ICD-9 code. Procedures we looked at were low anterior resection, both open, laparoscopic, and robot, using these codes. We went ahead and excluded anyone younger than 18 years old, concurrent rectosigmoid cancer, as well as anal malignancy. Once again, the data points recorded are morbidity, mortality, length of stay, discharge disposition, as well as age, gender, comorbidity, and charges. We used the statistical analysis. And furthermore, discharge disposition has 4 categories: home with home health, transfer to acute care hospital, as well as admit to nursing home facility, which is like rehab. So this is a national trend of patients with rectal cancer patients undergoing LAR. Sorry about the color not really showing up, but hopefully this can highlight. The upper trend shows the open LAR cohort. The blue is actually lab, and the gray is actually robot. We analyzed over 43,000 patients. Y-axis actually shows the percentage of total LAR cases, one representing 100%, plotted against years 2009 through 2014. I would like to highlight the fact that in 2009, 91% of LAR were done openly, while only 3% were performed robotically. Fast forward that to 2014, 77% were performed open, while increasingly 15% were performed robotically. Also, I would like to highlight the fact that conventional laparoscopic LAR numbers stayed relatively constant. It's a busy table, but we divided our group once again to open, laparoscopic, and robot. The top line shows the total number of patients in each of the group. As you can see, the median age for open was 62, and for both laparoscopic and robotic groups were 60. Majority of these patients were male. Also, I like to highlight the fact that the length of stay when compared to the open cohort, both laparoscopic and robotic groups had statistical significance of going home earlier than the open group. However, there was no mortality difference, among the three groups. Once again, this is a continuation of table 1, where all of our cohorts have been discharged. Surprisingly, majority of all three groups went home without any assistance. However, the robotic group did require a little more home nursing and assistance when going home. There was no statistical difference when analyzed where the patients were discharged, including skilled nursing facility. And the most interesting fact, I suppose, is the last line. We tried to break down the hospital charges per day as well. As you can see, open group had approximately $8,648 per day. Compare that to about $14,000 a day for the robotic patients. Secondly, we wanted to look at post-operative complications. What was interesting is that compared to the open group, laparoscopic and robotic group had lower infection rates, and this actually includes both superficial and deep infections. Also interesting was that our intraoperative complication, when we compare the three groups, robotic group had the least intraoperative complications. So in discussion, there is a national rise in robotic LAR, as you can see. Both laparoscopic and robotic LAR cohorts had shorter length of stay, decreased infection rate, and intraoperative complications for robot cohort. However, despite this trend, the vast majority of LAR cases are still being performed openly. Contributing obstacles, perhaps, to wider adoption of robotic LAR includes needs for special training for both the surgeons and the team around the surgeon, and perhaps higher charges. Of course, our study has several limitations. It is a retrospective study. It uses a very broad NIS database, does not include any specific surgeon or particular methods, and there was no oncologic information available for us. Thus, in conclusion, our study shows that there is a national rise in robotic approaches in rectal cancer surgery. Minimally invasive LAR has shown shorter length of stay, no mortality difference, lower infection and intraoperative complications, with a higher total hospital charges. We look forward to the current and future studies and effort for wider adoption of laparoscopic and robotic approaches for rectal cancer treatment. Thank you very much.